Anytime there's a change, we should ask the question of why. Well, here's the short answer. Beginning in 2019, many of the MCs around the state partnered with the Michigan Stroke Program, formerly known as Mosaic, in order to see how we were not only identifying, but treating strokes. As we started to look at the data, here's what we found. In the most recent quarter of data that we have, what we found was that 61% of the time, our EMS crews were able to correctly identify and treat strokes. However, that means that 39% of the time, our EMS crews were not able to identify strokes, which leads us back to the question of why. Why are our EMS crews not able to identify strokes and then treat them at a higher percentage? Well, that's where our data comes in. As our EMS providers know, not all of our patients fall into the same easy box to identify strokes. Some are LVOs, some are hemorrhagic, some are ischemic, and they all present slightly different. Even though the general signs and symptoms are the same, not all of those patients are easily identifiable. So we looked at the top primary provider impressions on all of the patients who we were not able to identify strokes in. And what we found was really not that surprising. The top 3 provider impressions where our EMS crews were not able to make that time-sensitive determination were altered level of consciousness, weakness, and dizziness. Now that we say that, it probably doesn't come as that big a surprise. But that's not the whole story. We dove deeper into the cases that EMS was not able to identify strokes, and what we found was there were some things that were there that potentially could lead us in the correct direction. However, our current stroke scale, the Cincinnati stroke scale, did not include some of those questions or raise enough red flags for our providers to make that determination. 2 of those items was a sudden onset posterior headache and expressive aphasia, which is the saying of words that are not intended. So if you're looking at the blue sky saying that it's red, or saying a cat is actually a dog. Additionally, one of the other things that would pick up on some of the strokes that we were missing was the finger to nose test. And we will demonstrate some of these techniques as part of this update a little later on. This all brings us back to why. Why do we need to make the change? Why is this so important? Well, here are some other pieces of data that we found very impactful and really kind of drove this message home. When EMS providers actually suspect a stroke and it's communicated to the hospital systems before they arrive, then the door to CT time is 14 minutes. However, if our patients fool us or our EMS providers do not pick up on the stroke, then that time balloons to 37 minutes. We know our patients do not always call for EMS right at the onset of stroke symptoms or many of our other complaints that we're treating. So because of that, any time that we can shave and save our patients is vitally important. We see similar findings with TPA times. So again, with EMS suspecting stroke, our number is about 34 minutes from the time they hit the door of the emergency department before TPA is actually being administered. And with those patients where we don't anticipate or suspect a stroke, that number balloons to 89 minutes in our system. So that's the why. So now let's look at the what. And the what is the new stroke assessment that we're going to be looking at. That is going to be called the BEFAST Plus. And the plus stands for those extra little questions that will help us identify those strokes that were a little bit more challenging for us to find, specifically posterior strokes, which made up a large portion of the strokes that our EMS providers were unable to identify using the current system in place. So let's look at the different components of BEFAST Plus. The B stands for balance. When we're looking at this one, we would like you to specifically look for sudden trouble walking, dizziness, or loss of balance and coordination. The E stands for eyes. Ask about sudden trouble seeing in one or both eyes or double vision. Facial droop. Have all patients show their teeth or smile. Arm drift. Have the patients close their eyes and hold both arms straight out for 10 seconds. What you're going to be looking for is arm drift. Abnormal speech. Have all your patients say, "The sky is blue in Michigan," and look for any types of abnormal speech, not just slurring of speech, but any abnormalities. And the last part of the BEFAST is documenting the time last seen normal for the patient. Any findings outside of normal would be considered a positive BEFAST stroke scale or stroke screen. Afterwards, we're going to have you do 2 additional tests. And these specific parts of the stroke screen will be looking for posterior strokes. The first one is a finger to nose test. We would like you to demonstrate this to the patient and then have the patient repeat it back to you. I'd like you to hold your hand about 1 to 2 feet in front of the patient at eye level, then have them take their finger, touch your finger, and then back to their nose, alternating arms. The second part of the additional questions would be to ask the patient about a headache and ask if they're having a new onset posterior headache. Any deficits found, the assessment is considered positive for stroke, and a stroke call should be made to the receiving facility. Other items that we'd like to make sure that you include with your report. First, we would like to make sure that you include a blood glucose level. Second, we would like to make sure that you start an 18 gauge or high flow 22 gauge IV in the right AC. This will help with the care that the patient will receive at the hospital. And also, we would like to make sure that you either have the person who last saw the patient well or a good contact number that the hospital can reach out to that individual once your patient arrives. Many times there's a lot of questions that come up that those individuals would be able to answer better, and there may be a delay just waiting for that person to arrive at the emergency department or to be able to contact them without that number. Thanks for taking the time to listen to this presentation today and all of the hard work that you guys do each and every day, not only to treat our stroke patients, but every other patient that is in our system. This really couldn't be done without your help and your dedication, and we just really appreciate that. Thank you so much.